The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Building Confidence in Your Treatment Decisions and Care. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Priya Kumthekar is a board-certified neuro-oncologist in practice at Northwestern University. In her practice, she takes care of a large variety of primary and secondary brain tumors. She also is heavily involved in clinical and translational research in brain tumors and clinical trial development, looking at novel brain tumor therapeutics. Thank you so much for joining us, Dr. Kumthekar. You may now begin your presentation.
Great. Thank you, Umbreen. Thank you all for joining. I'm really excited about today's talk about managing our care and beyond the clinic. Just to kind of set the theme for the day. By the way, these are my disclosures. This might be a little different than other webinars you've come to, and including other ones that I've done for ABTA. Really what I want this to be is a roundtable discussion, and I want to present a lot of things just beyond the science. I encourage you to come to some of our science webinars and listen to some of the talks about clinical trials and translational studies that are so close to my heart. But nothing is closer to my heart than my patients, and I think that's what today is about: is how to really leverage that relationship and be your own advocate in the clinical setting. And so today is, I think of it more of like a fireside. I am, here in cold Chicago, so fireside chat is welcome. I have my tea, and we just really want to go over some of these sort of gray area topics with you guys and have you all give plenty of time to ask and answer questions. So there's going to be less slides today and more chatting. There's a few main topics that I want to cover, and really I'll touch on, and then we can again pause to have questions. So we'll talk about managing your care and your care team, because there are multiple people involved in you or your loved one's care, and how to communicate with your doctors and providers, how to be your own self-advocate, how to manage things like second opinions, and that includes opinions both within and outside of healthcare. So also managing very well-meaning and loving friends and families' opinions that also, of course, are pouring in. So again, the format today is less lecture, more discussion. I'll give kind of 4 mini presentations of a couple slides, and then I'll pause, hopefully long pauses for that Q&A. So the first area that I'll cover today is effective communication and self-advocacy, not efficacy, advocacy. So a significant part of your care happens outside the clinic. I always tell my patients, I'm getting snippets, 10 minutes, 20 minutes, 30 minute snippets when we're in the clinic. But there's so much more than just what happens in that time frame. There are logistical things like medication refills, asking medical questions about your labs, maybe running past your care team what your symptoms have been at home. And particularly in the past couple of years, we have a lot of COVID-19 related questions about which doctor should we see for what. There's so many things that come up that don't always arise in the clinic setting itself. And then, of course, there's logistics and scheduling. How am I going to coordinate getting the MRI with the clinic appointment and that tight balance? So that's one thing that I want to talk about, as well as when do you contact your doctor? I think everyone here wants to be thoughtful about not over communicating, but the question is, are you under communicating also? What needs to be communicated when, and under what circumstances? And I think this is another really important one that I talk to my patients about. What needs to be a routine communication? What needs to be an emergent communication? There are a lot of gray areas there. And also what platform to utilize, whether it's the electronic medical record system, phone, email, MyChart, so many different platforms by which we communicate with our doctors. And sometimes it's not just one solitary answer, it's depending on that actual clinical setting. So I put here a whole bunch of information and some really key takeaways in red. So the number one thing is that clinics are different, clinicians are different, doctors are different, nurses are different, even within a clinic. So I think it's really important as you lay the foundation of your relationship, just to ask your provider, what might be the best mode of communication, understanding the team that your doctor works with. So when I meet my patients for the first time, I like to, invite them to meet the whole team. So my nurse practitioner, the nurse that works with us, the medical assistant, the social worker. And sometimes it's a lot for one meeting, but over those first few meetings, you kind of want to understand that whole network that makes up your doctor's team, because of course your doctor has a lot of patients, and it takes really a village to make sure that we're caring properly for all of our patients. So understanding how you communicate to each person on that team, and maybe some prefer email, maybe some prefer to be called. And so asking is always the right answer. And I think this is really important no matter who and where your care is given. I think it's really, really key to have one main point of contact from the caregiver side and communicate who that person is. And when I say communicate who that person is, I think that communication needs to happen both within the patient side as well as the healthcare side. So, for example, of course, our patients have multiple loved ones who love them, but we don't want to be talking to mom and then dad and brother and sister and having different messages be sent. You want that one primary contact liaison that the healthcare that's communicating with the healthcare team, and that the healthcare team is in turn communicating with. So it's really, really nice to have that person established. And sometimes that takes a conversation amongst the family, amongst the circle of people who are caring for the patient, to then make that decision, number one, and then two, communicate that decision to the healthcare team. Because otherwise it can be very confusing for not only a family, but also for the clinical care team. Another really important point that I put here in red is just coming to visits prepared. I know I do this even when I go to my kids' pediatrician visits. I keep a list on my phone of the questions that I accumulate that I know are not necessarily emergent, but that I want to ask at my next visit. And I think it's really important to do that in some way, shape, or form, whether it's in a journal that you keep or a notebook, or whether it's a list that you keep on your phone, because your providers really want to be answering all your questions, and they want to do it in the most organized fashion possible, and make sure that, it's not, oh gosh, I saw the doctor yesterday, but I forgot to ask, blah, blah, blah. Not that that's not allowed, of course, but just being organized and prepared for those visits. There is scattered through here, we have some resources available on ABTA as well that I'm sure Umbreen can speak to at the end also, but abt.org does have a lot of really great information for both this topic and others. So there's a handout that you can download on questions to ask your doctor, and just some more details on that. And then lastly, and I think sometimes the most difficult, is just medical emergencies as a whole. So I give my patients my email address, for example, for them to reach me directly. And the first caveat is I say, please do not ever email me emergency, because if you do, and I don't check my email for hours, I would feel absolutely terrible that we've missed an emergency. So understanding which platform that you communicate that emergency to your healthcare team is super important. And I think one step before that we often don't talk about is, how do you even recognize a medical emergency? I think that's hard enough to understand. So that's a great question to ask your provider on what is an emergency, how might they handle it, and how is that best communicated? So I'm going to pause here and see if you guys have any questions on anything that I've said so far.
Thank you, Dr.
I can look at the chat here. Yeah.
Yeah, as a reminder, if you have a question that you would like to ask, please just type and submit it using the Q&A box, and we'll answer as many questions as time allows. So let's see what we have here. Okay, so one question we have is, you talked about coming to your appointments prepared, with questions to ask, maybe information on how you've been doing. And a great way to do that is, like you mentioned, using a journal. But can you share if there are any tools or apps that you're aware of, maybe that some of your patients have used or mentioned, that patients and families can use to help collect and keep all of this information? Sometimes it can be so overwhelming. And as we know, once we step foot into the doctor's office, all those questions kind of get forgotten. So what advice or what tools can you share with our audience today that can be helpful?
I don't have an app per se. Maybe I'm a little bit more old school in that way. I recommend that my patients get a binder of some sort, or because folders tend to get full, that they keep organized, that they have, notes in one part where they have the date. So let's say you had a clinic visit today, January 27th, 2020, key points, key takeaways, so that you can also go back to those notes and you get, let's say instructions on paper that you're putting in there. And then you have a separate section of, say, MRI reports, or a separate section of pathology reports. I think keeping something like that organized in a binder is invaluable. So that's what I recommend. I think journals are also good. I think a lot of people do that. It just doesn't allow you to actually stick in some of the medical information that you get over time, because it's a lot of stuff to squish in your head. It's almost like your walking brain on all the information that you need.
Great advice. Thank you so much. We have another question here that I think is very important, because a lot of patients like to incorporate, complementary treatments and methods as well to help manage their symptoms and side effects that they might be experiencing. How can patients and families communicate this with their medical team? And what do you do if there's differences in opinion between how a patient wants to manage their care and what their physician or care team's approach is?
Yeah, I think there's a few things to unpack there. And the first is ask. The first is speak and communicate it. So communicate what your desires are and why. And let's say that there is something that you and your doctor don't agree on. Ask why. I think that's really important. I can tell you that there's typically a reason behind most of these questions or answers. Someone, for example, I have a ton of patients who also incorporate naturopathics in their regimen, but that doctor-patient trust is that they tell me each and every agent. And the reason for that, I can explain the why for everything that I do. And that why is, I just want to make sure that that patient's safe. And drug-drug interactions for naturopathics or not for naturopathic meds are not always clear and don't always have, I think a lot of people have the notion that because it's natural, it doesn't intermix with anything. So sometimes that's the reason why. But I think the key is understanding why, having those conversations with transparency with one another. And then that's the most successful way. And I think just a step backwards from that is just understanding that, we're just people communicating with people, right? Your doctors are human beings just like you. And so not all human beings agree on every topic. And I think being able to have things that you feel differently about is fair, and understanding the why is fair. So if it's something that's unsafe, then you won't do. And if it's just that, hey, my doctor doesn't like this, but I know that it's safe, I think that yields a different outcome. So understanding the why, having transparent conversations, and understanding that at the end of the day, everybody comes to the table with a personality and with that sort of with that history and depth of history. I know that's sort of a long answer. I apologize, but does that answer the question?
That does. Thank you. And I think that was a really important topic. So I really appreciate your insight on that. Another question we have, so we talked about the importance of coming to your appointment again prepared with questions to ask. And we shared the resource that the ABTA has on our website with a list of questions that you can ask. But can you maybe touch on what you, as a physician, think would be some important questions that patients should keep in mind when they're talking to their medical team? How do they know what questions to ask?
Yeah, that's a really broad question, and one that can't be answered in one simple sentence. I think the questions are the questions you have. And I think it's also really fair I'll tell you one cheat sheet question that I often bring up is, actually I had a patient just ask me this yesterday: what haven't I asked you? And I think that's really fair. If you're at the end of your visit and you feel like you've gone over all of it, but you haven't, you might just throw out there, is there something that I should have asked that I didn't? I had literally had a patient ask me that yesterday, and I thought it was so appropriate. And I actually did have a couple things that they didn't ask that I thought I would just throw in there. So I think that's always the catch-all at the end, if that's sort of what you're looking for. And then I think the other broad stroke of that is ask whatever questions you need for mental clarity and to feel at peace with the decisions that have been made.
That's great. Thank you so much. I love that question of just asking, what haven't I asked yet? I think that's a great point to start with. So we have a question from the caregiver perspective. When we're caring for a loved one who has a brain tumor, sometimes anything that they're experiencing can be seen as unusual and as an emergency to the caregiver. So how can those people who are supporting their loved one tell the difference between what is an emergency and what isn't?
Yes. And I have to say hi, Bev, because this is my friend here. So great question, Bev. I think that this is hard. And I think especially now in the setting of COVID, the answer has been a little bit different. So the number one thing is that patient safe, right? And that brings about a lot of clarity and cuts out about 8 things from the list. So if a patient, accidentally has an additional Tylenol or an extra Keppra, everything's going to be okay. That patient's safe. They got, a little bit over-treated, but it's not like an overdose. So understanding that clarity off the bat is that patient safe? And then, can I handle this at home? I think that's really important. And then there are the details. So those are broad stroke answers. And then there are in the details of things that I would want you to talk to your doctor about. So things like, when do I need to go in for a seizure? So for example, my patients who have seizures, I tell them if they have, a focal seizure of their arm, for example, that stops on its own, they don't need to, that's not a medical emergency, right? It was focal, they retained consciousness, it was self-limiting. But if they have a full-blown seizure, of course, that is a medical emergency. They should call 911. And also, I think understanding that the normal things that you do for an emergency are still in place. So if it's a medical emergency, call 911 before you call me, because I want to see that EMT coming in before you download the story to me, because the most important thing is safety first for that patient. So it becomes these questions the answers start to sort of appear with more clarity once you simplify them. So what's going to keep the patient safe first? What do I need to do if this is emergency and the patient, and I didn't know he had a brain tumor, for example? You call 911 right away, right? So remember that not the whole playbook doesn't change just because there is a diagnosis. The playbook for what you would do for an emergency, even before the brain tumor diagnosis was there, still holds true.
Thank you so much. I think we'll take 2 more questions. This question I think is great. So sometimes self-advocating, which is what we've been talking about, it can get exhausting, especially when you as the patient are going through it alone. Maybe you don't have a strong support system of family and friends that are going through this with you, and you're the one who's really doing all of that advocating for yourself. What resources or support is available for patients that are going through this alone and are starting to feel that fatigue from having to speak up for themselves so often and advocating for themselves so often?
Yeah, it's such a great question, and such a reasonable response to have that fatigue. And I would say there's a couple different things. So if there truly is no trusted loved one, caregiver in that life for that person to bring to the appointment, there are great synthetic ways to create that as well. There are actually advocacy services that are available. And I don't know the details I won't be able to rattle off the names of the services right now, but if you look for patient advocates, they actually exist. So you can employ a patient advocate to actually help you with some of that, because it is exhausting to do all that on your own. And so I think that that's a really, really fair question. And then the other thing, so that's on your end, you could look for a patient advocate. I don't know if ABTA has something accordingly, maybe afterwards, and bring you can maybe speak to that, but also on the clinic end. So for example, we have a brain tumor specific social worker who I could bring into that scenario, who could potentially help out as well, because I know we have a lot of other services that we connect our patients with, such as, Immerman's Angels and other similar programs where you have like a mentor-mentee relationship with other people who have gone through similar things, so that they can, in essence, serve as an advocate as well. So if you don't feel like you naturally have an advocate in your life, there are ways to find one and to sort of be matched with one outside of someone who's not organically in your life.
That's great. Thank you so much for sharing those resources. And if you are looking for more resources and support, I also encourage you to reach out to the ABTA Care Line. You can call at 1-800-886-2282 or email us at info@abta.org. And any of our Caroline staff will also be happy to help navigate and provide you with the support and resources that you may need at that time. So we'll take one more question before moving on to the next section of this presentation. And this question is about how to handle or what to do when you feel like your doctor isn't listening to you, or you don't have that strong, good relationship with your doctor, which can impact having effective communication. What can a patient or family member do in those situations?
Yeah, I mean, I think that there's just like any relationship in life, the broader philosophy is twofold. One, you work to grow that with that doctor, and I can get into that in a moment. Or two, you decide that, this is not quite the growth of relationship I want. I need to feel like, I trust my, caregiver a little bit more. And you might choose to get a second opinion and see if that feels different. But in terms of path one, to try to grow that, because again, we're all just human beings, right? And sometimes these deep relationships of trust don't happen overnight. And so how you can grow that is just that transparency. I think saying, I think looking for that transparent communication, and even saying that, like, we've really appreciated the care that you've given us to date. Just want to make sure that you hear us out when this is my primary concern, and I just really don't want to, I want to make sure that we address it today. So I think, coming and putting the spotlight on that concern that you feel like is not being addressed is really key. Sometimes it's hard if you have 12 spotlights at the same time. It's hard to address, a dozen concerns at once. Often what I'll tell my patients, if we, let's say, have 10 concerns, then we prioritize that in terms of what we knock out one by one. So I think even having that conversation about maybe what you're prioritizing, what you're deprioritizing, and if you feel like the right things aren't being prioritized, you can then call that out. Great, I know you hear me on this. This is one thing that's really keeping me up at night. Before we leave today, can we address a plan? Can we have a plan to address this one issue that I think needs to be better addressed? So I think calling it out and understanding in a very sort of non-combative way that it's not often because people aren't trying to hear you or ignore you or anything like that. It's just more that sometimes there's so many moving parts that it gets lost in translation what that prioritized concern is. So I sort of, my response would be to sort of speak that concern and highlight it, spotlight it, and have a plan for it, even if it's not fixed in that moment.
Thank you so much. We'll move on to the next section of the presentation. For any questions that we didn't have time to address, we'll try to address them at the end of the webinar. Thank you.
All right. So the second topic that we'll move on to is treatment decisions and engaging your provider, which really has a lot of overlap to some of the questions asked already. So I think we're keeping in theme. So, there are different categories of decision making, and I explain this to my patients as we kind of have this web of decisions to make every visit. The key example that I give is symptom management versus tumor management. Of course, as the patient and as the care team around that patient, you truly are the driver for all of these decisions. However, there often tends to be a little bit more of a assertiveness in the treatment and the actual tumor directed therapy decision making that often comes from your oncologist than, for example, symptom management. So when I think to my clinic yesterday, there were many, tumor related symptom decision making that needs to be made. And I tend to be relatively directive with that and give the margin of error of kind of choice that families have. And then when it comes to, say, symptom management, that leash is so much longer. I hate even calling it a leash because that's a terrible analogy. But so, for example, if I had a patient yesterday who we talked about his fatigue, and I said, these are the choices. I think some of this is happening because it's winter and you're not getting as much physical activity. So you are, it's making you more tired. And so do you want to increase your energy by let's make a plan today on how you're going to get more physical activity? And I can also, prescribe you a stimulant that could put that pep in your step, but you'll have to take another pill. And so having those conversations, those are things that I generally tell my patients, listen, I want a lot of feedback from you. I really want you to drive that decision making. And I'm certainly a part of it, but you're more in that driver's seat versus the treatment, tumor-directed treatment. I'm probably more in the driver's seat and I need you to help me make those decisions, but I'm really kind of steering that ship. So we're all working together as a team. Everyone's a part of every decision, but understand that there are different pieces of your decision making that you're steering maybe a little bit more, maybe a little bit less. And I think really importantly, not all questions have black and white answers. And I put this gray area thing here because I just thought it was apropos for our brain tumor awareness gray ribbon. I mean, it's really the art of medicine. And while there are certain standards, for example, standard of care, first-line glioblastoma is pretty standard. There are small deviations, but it's generally pretty black and white. But in recurrence, it's really gray. And so understanding that and I tend to just tell my patients and their families, listen, this is the decision that I'm leaning towards. And just so you know, this is a very gray area, or this is the decision that I'm leaning towards. And just so you know, it's pretty concrete, just kind of explaining to my patients and their families where it stands on there. And if you ever are unsure of that, you can always ask, like, is this a gray area? Or is this standard? Or is there a standard even? So, but just understanding that concept, I know, growing up, I thought that medicine was so straightforward and they were just answers that fit into boxes. And I'm sure you all are understanding that as you get deeper into your care, that's not always the case. Another thing that I always explain to my patients is, yeah, you need an advocate, sure, but it's not a team. We're one team. It's not like the team that the patient brings and the team that the care team brings. We're all on the same team, and your healthcare and your doctors and your teams are your advocates also. And I think really importantly, that doesn't necessarily mean that every advocacy item is done by your doctor or the care team, because of course, it's a team approach. And I think really importantly, it's important to know that your doctor has a lot of other patients also. And that doesn't mean that should take from your care. It just means that we really try to give equitable care to all of our patients. So if two patients are coming for the same reason and they have the same, let's say, level of acuity, to give 10 minutes to one and 2 hours to another, isn't really fair because there's only so many hours in the day. And so just kind of understanding that your doctors and your healthcare teams are trying to balance giving you all of their time and energy and advocacy while still not taking for what they need to give to their other patients. So just kind of understanding that in the whole ecosystem of what your doctor is doing. So here are some of my, again, unsolicited advice here. Some key takeaways in red again, and some other things that we can talk through. So the first is really important, and I can't stress this enough. Not every decision needs to take place in the 10, 15, 20 minutes, 30 minutes, whatever it is, moments that you're with your doctor. View the doctor's visit as especially when you're making difficult decisions, so treatment decisions or other things, any decision that you feel is difficult, don't feel like it needs to be made in that moment. It's just like anything else in life. You have the opportunity to think about it. And I tend to put sort of expirations on when my patients can give me decisions by. So I had a couple patients yesterday where I'm like, here's all the info. I want you to go home and talk about it. I want you to talk about it with your loved ones. I want you to sleep on it. I want you to talk about it behind our back so that, you know, you kind of get that, you feel like you're not, you know, being pressured to feel one way or the other. And then let's circle back on Friday, or let's have this answer by Monday morning. So some sort of have your own mental kind of deadlines for those decisions, but know that not every decision needs to take place in the clinic. But what does need to take place on that clinic visit is make sure you're gathering all the information that you need to then successfully, you know, make that decision. There's of course always exceptions to it. You know, I often get an email on Thursday after a Wednesday clinic of, oh, I just didn't ask this one thing, and that's perfectly acceptable. But just again, trying to be organized in your information gathering, to be respectful not only of your doctor's time, but also to make sure that all the key players are in that room when you're asking that question. It's just kind of respectful of everyone who's behind that decision making. And I think also importantly, there are things that you'll make your own decisions on, but if you do make changes to your medications, or if you're taking any supplements or herbals, as we alluded to earlier, make sure you communicate that to your doctor and your care team. That shows your team that, you know, that they're a key player in it, right? That they're not just somebody who prescribes meds for you, but they're somebody who is a part of that holistic approach, and that they're a part of every crevice of your treatment. And then this is a really tough one, but understand which doctor makes which decision. Many of you have many doctors, you know, a neuro-oncologist, a radiation oncologist, a neurosurgeon. And while your team makes decisions together, and there are lots of platforms for that, tumor boards and just picking up the phone and calling each other, which we do frequently, there still are certain decisions that are driven by certain doctors. So doing radiation for a second time, or deciding whether to do, you know, stereotactic radiosurgery or wider field radiation, that while everyone's going to be a part of that decision, it's really going to be driven by the radiation oncologist. And similar and respectively for surgical decisions and medical therapy decisions. So just kind of understand. And if you don't know, no big deal. Just ask, who's ultimately going to be making this decision? And you'll get your answer. And I think, again, trying to consolidate your questions is really key. So by consolidating the questions, it doesn't just mean making your questions less. It also means consolidate who's giving those questions, what the time frame by which it's happening. So hopefully all within the visit, ideally. And really just that comes with being organized and prepared to that actual clinic visit. And understand sort of what requires an office visit versus email versus telephone. Again, I give my email to a lot of folks, and then on occasion I'll get an email with about, you know, 8 or 9 questions embedded in there that I would need to literally write a 1-hour novel back. That's an appointment, right? We can set that up. You know, reach out if you have a lot of questions. Most of your doctors are willing to add you on last minute, double book, triple book. You know, I'm always willing to do that. But what I'll tell you from a physician perspective, certain conversations need to not be typed. Certain conversations need to be conversations, so that you really get to ask those counter questions to it as well. So So a quick question of, am I allowed to take curcumin? That can be, a my chart question, or certainly, it's better in the office, but that's a pretty straightforward question. But a series of questions about what is the risks versus benefits to treatment X, or should I do X versus Y versus Z? Those tend to be not linear answers, and they need to be a conversation out of respect to all parties who are making those gray area decisions. Remember, a lot of these decisions are not black and white. So just kind of understand what constitutes and what goes into each of these different scenarios. So I'll pause here again.
Thank you so much. Again, as a reminder, if you have a question that you'd like to ask for this section, please type and submit it using the Q&A button, and we'll answer questions as time allows. So one of the first questions we have is asking, you had mentioned that there's some aspects that your healthcare team takes the lead on in making decisions, and there's some aspects that you expect the patient or the family to take the lead on. Can you elaborate on that a little bit more? Maybe explain what areas you see as being more under the healthcare team, under your doctors' leadership, and what areas you expect the patient to be taking the reins.
Yeah, and the foundational answer to that question is also that all members are a part of all decisions, generically speaking. But some do, to your point, and to use your words, do take the reins. So understanding all the treatment optionality often comes from your doctor. It doesn't mean it exclusively needs to. If let's say you found a clinical trial and maybe your doctor doesn't know about it, and you decide to bring it up as an option, that's you being a driver in there. And the doctor might respond and say, yeah, this is a great option for the future, or this is a great option now, or actually, this wouldn't be an option because XYZ. So it doesn't mean that the doctor is exclusively the driver for the treatment decisions, but the doctor is the one that you have employed to play that role. So naturally, the doctor will tend to be the driver of those treatment decisions. When I explain it to my patients, it's more of like a symptomatic side that I really, really need to understand what the patient needs, because from a quality of life perspective, we all have a different definition of quality of life, and it's all in the same probably realm, but everybody sort of measures that differently. So to go back to that fatigue analogy that I gave earlier, so some patients don't mind if they're taking a nap a day. Like, I'm really tired, but I'm taking a nap a day and I'm totally fine. I don't need to do anything to modify. Versus others might say, gosh, I'm really tired and it's driving me crazy that I'm taking a nap a day. And so those are two identical patient scenarios with two kind of different answers as to how we manage it. And so that's what I mean by patient driven, understanding the depths of how the symptoms are impacting that patient and how they want or might need it to change. And also what they might be willing to do. Some people say, gosh, I don't want to take a single other pill. I really appreciate the fact that it might be helpful, but no, I'm good. I'd rather be a little tired and try to make it better in other ways than to take a stimulant, for example, to which I would say, great, let's talk about those other ways. So that to me is kind of very patient driven. I think another great example of that is tremor. And as a neurologist, so even, forget about the neuro-oncology part, but as a neurologist, it's even in our boards. When do we start patients who have essential tremor? When do we start them on meds? And actually, the correct answer is when that bothers that patient. And so there's different scales for each person on how it might bother or impact that patient. So we really need to be listening and letting our patients drive some of those decisions. The way that I see it is, it's up to me to make sure that I'm bringing solutions to the table for a lot of those symptomatic factors. But ultimately, it's up to my patients whether or not that they really want to pursue it or not, because they're the ones living with those symptoms every day. So I'm not going to, I'm not going to force a Tylenol on anyone for a headache. They're going to decide, is this headache bad enough for me to want to take a Tylenol?
That's
Sorry,
really helpful. Thank
probably
you.
long-winded. I apologize.
No, that was great. Thank you for kind of helping to decipher between those two different aspects of making decisions in your care. So when a physician is presenting, maybe two different treatment options to the family and the patient, what are some important considerations that patients and families should keep in mind? What do they need to know to make an informed decision and choose what will be best for them and their care?
So I make every decision in my life based on risk-benefit ratio. So whether that is what treatment we're going to do for a patient or what treatments we're going to propose to a patient and family, or what I'm going to have for lunch. I think things really boil down to what are the risks and what are the benefits here, and am I willing to accept the risk for the benefits, or are the benefits not worth it? So whenever you're thinking about treatment decision making, there's like a few key things. So number one, risk benefit. Number two, will I have any regrets in either direction? So this is a big one. Again, another thing that I employ in my own life, both in the clinic and outside of the clinic. Will I have any regrets? What will help me sleep the easiest at night? I mean, at the end of the day, we all sleep with our own decisions and with the decisions that we make for our loved ones. So they really need to come down to, in broad strokes, risk benefit. So ask every question about the risks and the potential benefits when you're in that appointment. And then the other ones are kind of more internal, and why I often have my patients sleep on things. So will I regret it? So that could look in a couple different ways. Like, will I regret not trying this clinical trial? Or will I regret doing it because I'm not doing X? Or will I regret doing it because I don't want to travel? Or, I'm just giving that as an example. So risk benefit, will I regret it? And what decision would I sleep best with at night? So those are kind of generically broad strokes, what I would think about when making a decision.
That's really helpful. Thank you. Another great question we have is asking, what can a patient do to help regain confidence in their care team after they've been left feeling uninformed or unheard of and left out in their care needs?
Yeah. So this is a thicker question, and actually a little bit of psychology in this one as well, right? And it's a whatever the circumstance, it's a fair feeling that I'm sure occurs. And I think the number one question that you need to ask yourself is, will I be able to regain it? Will I allow that? And that doesn't just fit the what caused you to lose your trust, but also, do you have the capacity to re-trust again? And we've probably all been there in some way, shape, or form with any relationship in life. But if you're talking about repairing a relationship or improving upon one, which we've all had to do both within and outside of the brain tumor setting, you should ask yourself whether or not you have the capacity to improve it, and whether you really, really want to. So if the answer to that is no, if you feel like there won't be a situation where I will regain trust, then it might be worth it. Because again, if it'll help you sleep better at night to have trust in your provider, then it might be worth it to potentially just, try to seek another provider, or try to just meet somebody else if that would give you peace of mind. But if the answer is you feel like that can be regained, then it's going to be a two-way street. So it'll be one, you being open to it and being honest with yourself for it. And then two, I think there are respectful ways to say, listen, if there's concrete happenings that led to that, I think it's fair to say, to take a minute and say, I just want to let you know that I'm really appreciative of your care. When X happened, it made me step back a little, and I'll be honest, I lost a little trust, but I really like you. I really appreciate the care you've given, and I'd really like to rebuild that. If you feel like that's something you want to say, or if you feel that that's something you're comfortable saying. So there are different ways to rebuild, but be honest with yourself on whether you want that and whether you think it's possible.
Thank you. I think we'll take one more question for this section before moving on. This question is asking about what are the patient's rights in accessing their information? For example, do they have the right to obtain copies of their radiation, of their MRI images, of test results, things like that? And how can they obtain that information?
Right. Of course you have the right. It's your information. So the short answer and easy answer is yes, you have the right to all of your information. The longer answer is how you get it. So it sort of depends, right? If I saw patients yesterday and they want a copy of their labs, easy, print a copy of their labs, hand it to them, or they want their report from their last visit, no problem. When you want things like discs or larger, quantities of medical records, you often need to go to medical records. And again, that health information belongs to you. So the shortest answer to your question is calling your medical records, which every healthcare system has a medical records department. And you can ask for the records that you're looking for, and you can ask them how you obtain them.
Thank you so much. That's really helpful. We'll go ahead and move on to the next section of your presentation.
Great. All right, so navigating second opinions. So first of all, I often sort of push my patients to get a second opinion. I think a lot of folks are similar, but your doctors are aware, I think, in short, that second opinions are a thing. And I think many of them probably have pursued such in their own healthcare. So really understand that providers are typically quite open to second opinions and are not offended. And I realize in making this statement that I'm speaking for others that I maybe shouldn't speak for, but I'll at least tell you in broad strokes, most doctors are going to not be offended. Again, it's just a matter of how it's communicated. I would say most providers are so not offended that they're a great person to ask that. And there is a really kind way to ask that. Listen, I really appreciate your care. This has all been so new and different for us that I think therapeutically we would love a second opinion. Is there anyone that you would recommend? I think that if and when my patients have asked me that, I welcome it with open arms. Because again, that black, white, gray, and the art of medicine, again, we understand that that's the case. So again, bottom line, second opinions, welcome. But it does come with the cautionary tale, which is that too many opinions are just that. It's too many opinions. You're not collecting facts, you're collecting opinions. And yes, there are facts intermixed in there, but because of this black, white, gray, it doesn't mean that if one provider said one thing and one of them said another, that there's a right or wrong. And that's the most important thing that you should understand about second opinions, is just that everybody has a slightly varied way of doing things. If two artists made two different paintings of a flower, we wouldn't call one right or one wrong. They're just sort of two different flowers. And it's a little bit I know it's a little bit of maybe an extreme analogy, but it's nonetheless kind of depicts that art that medicine is to some degree. And I think navigating second opinion follow-up is really important. So if you're going to go to a second opinion and that doctor is going to rattle off a list of 100 different random things that they want your primary treating physician to do, make sure that you put them in direct communication. Make sure that you understand the why for each or the why not. Just really, really make sure that you're not just saying, I went to this second opinion and they want me to start on these 8 naturopath medicines, so order them for me now. Make sure that you respect your doctor to not only tell them about the second opinion, but when you come back and relay whatever information you have, that you do so in an open and respectful and conversational manner. Because again, everybody's on your team and everybody just wants to help, but we want to do it in a very team approach fashion. ABTA does also have a treatment center guide here, because if you are looking for help in finding second opinions and you don't feel like you're necessarily getting that from your physician, which is totally okay. Maybe they don't know other folks. There are different guides online that you can get that. So I'll pause here for some questions in this section.
Thank you so much. I think getting second opinions is an area that we always have so many questions about because it can be really confusing sometimes. And I think one point of confusion comes when you do have differing opinions from the second or maybe even third opinion that you got. And like you said, there is no right or wrong there, but the patient at the end of the day does have to decide what treatment they end up going with. Can you share what the physicians or what patients and families can do to make that decision? How do you decide from these differing opinions of what is best for you in your care?
The first is that you don't decide it alone in a vacuum. You talk to your doctor, you talk to your trusted doctor about what you've learned, and they can help you decipher. So bring it to your appointment. These are not separate silos. It's not, you're not cheating on your boyfriend. You're getting more information that you bring back to your other source. So this is not something that needs to be done behind anyone's back or that anyone needs to be offended by or anything. You're just, again, everybody is towards a common good and common cause. So take whatever you learned, bring it to your doctor and go over it together.
Thank you. Another question we have is, when looking at other physicians or other treatment centers to get a second opinion from, what factors should patients and families keep in mind? What numbers or what should they be looking for in another treatment center?
Yeah, that's a little bit more of a personal preference answer. And I would say, for starters, word of mouth is really valuable. So if you learn about someone in your support group or on the ABTA website, or if your doctor tells you, hey, listen, that's great that you want a second opinion, here are some good names. I think that really word of mouth is big. We're people, we're not numbers. So for me, I often get second opinions because of clinical trials. And so I think if you're looking at clinical trials specifically and you want to talk to somebody who's running a specific study, that's another great person to reach out to. But also if you're just looking for an opinion with another smart doctor who's going to listen to you and offer you good advice, then look for people who seem like that they're going to be willing to just talk to you as a second opinion consult. And that, again, often comes, you can figure that out through websites, platform, support group platforms, and other similar resources.
Thank you so much. And I do want to, again, encourage any of our attendees who are trying to find a treatment center to use the Brain Tumor Treatment Center guide on the ABTA's website. It does provide a great breakdown of, how many physicians, how many neurosurgeons, et cetera, are on the staff. And it can be a great place to start if you don't know where to turn to. All right, I think we have time for one more question because I want to make sure we have time for your next section, next section. So this question is asking about coverage for second opinions. Do you know if second opinions is covered by insurance? Is it an out-of-pocket cost if patients have to go elsewhere to get a second opinion? Or
I'm not the expert to ask in that, but I'll tell you what I think. And that's a huge caveat that I gave you in the first sentence. I believe that they are covered. But it's certainly going to be dependent on your insurance and who you see and where. So I would definitely ask your insurance company.
Thank you so much. We'll move on to your next section and we'll hopefully have time to cover any questions that we may have missed at the end.
Okay, so this last one is one that comes from love, but one that I talk to patients about all the time. In fact, right just before this call, I got off with somebody who really needed help on how to manage friends and family's opinions. And it sometimes feels like you're drinking from a water hose with what people are telling you, particularly early in a diagnosis. So, I have to say this, your friends and family love you and you mean well, and it's your fault for being lovable, right? I think that is the take home, that, you know, people mean nothing but good, I would say 99.99% of the time, but they just feel compelled to share anything that they possibly can because they just want to help. So I have some key takeaways here, just knowing that foundationally this comes from a place of love. The first is set boundaries with friends and family. You know, whatever that means to you, because if it comes to a point where it feels like it adds more stress than good, know that that's not the person's intention. So make sure that setting boundaries, that you set boundaries because you want them to help the way that they intend to. And I think it does have nice to have a scripted line of what can be helpful. You know, I'm guilty of this as well, of when a patient or a friend or a family member is going through something, my knee jerk is, okay, what can I do? What can I do? And often it's more like, well, I should just volunteer, right? As the helper, that's what I should do, is just grab something. And sometimes your helpers are wonderful people who, like me, have made the mistake of not coming to the table with an idea to help with. So be that person as the helpee. Have a list of stuff, you know, you need groceries picked up. You maybe need the kids picked up on Thursday because there's an appointment, or if somebody could take the dog out Saturday morning, just that one time so you can make it to lab to get your labs, or, you know, whatever it is, write them down. So when somebody asks you, you have an answer for it, because people do really genuinely want to help you. They're not just saying it. And I think really importantly, you're going to get a lot of information, and you do not have to be the arbiter of that information. You don't have to be the filter. Your team can help. So some of it is, you know, clearly sort of in left field. You know, I had a patient say, gosh, didn't you hear Brussels sprouts can be curative? I mean, some of that stuff is, you know, a little bit left field. Again, people just trying to be wonderful and helpful, but you can filter out yourself. And some of it maybe is really good information because people can be really smart and helpful. So having like a line in your back pocket is great. So for example, I tell my patients, you can just say, great, thank you for this information. I'll bring it to my medical team. Like, again, people mean really well, but you don't have to process all that information, have an answer, have a response right then. So I'm just going to pause there because this one we can talk about for a while. So we can do so. I think we have a couple minutes.
Thank you so much. So we do have a question from the caregivers again. It's a big adjustment to adjust from being, you know, a wife, a sibling, a child, to now becoming a caretaker for your loved one who's going through a brain tumor diagnosis. Do you have any advice on how caregivers can adjust to this new role while still respecting their loved one's autonomy and self-determination?
Yeah, it's hard. I think recognizing for what it is important and calling it out. And I think actually there's no one solution here and no one size fits all. I think it is helpful to get a third party help, whether it's a counselor of some sort, or even just having that conversation with the person you're caring for. You know, hey, listen, you know, let's talk. I still want the same, you know, friend relationship, you know, significant other relationship that we've always had. How do we preserve that and do this? How do we keep your autonomy and do this? What are the most important things for you to keep your independence? So I think talking it out with the person themselves, as well as bringing in a third party as you need.
Thank you. And if you don't mind, I'm going to open it up to questions on your presentation as a whole, because we do have some previous questions that we weren't able to answer that I think would be helpful to touch on. So one question we have is asking about finding the volume of procedures that a neurosurgeon has done. That's sometimes an important factor.
I saw that. And if you want, Umbreen, and for time's sake, I can go through them. Sorry, I don't mean to cut you off, but I know that we're at time. So I'll just go through them and answer them. So I think the question is, how do we go about finding out the number of procedures? I don't know, because it's going to be different per institution. I know we don't have that stuff published on our website of any sort. I think the only way to do it is just to ask that institution, unless they happen to have it publicly available. I really would not know. It's going to be heterogeneous depending on who and where, and if they publish it, and if they even keep track of it or not. So unfortunately, no clean answer to that one. Sorry.
Thank you for your honesty on that. And thank you again for this wonderful presentation. Unfortunately, that is all the time that we have for today. But I encourage you, Dr. Kumthekar, if you have time to stay on, and feel free to type and respond to any questions that we didn't have time for.
Great.
Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282.